a huge project. And this is we will talk about antimicrobial stewardship implementation. We will talk about learning objective. By the end of this lecture, each participant will know why antimicrobial stewardship is important and why we will implement this one. What is this program? What is antimicrobial stewardship? How can we implement antimicrobial stewardship? Who will involve in this program? And what is the metrics of antimicrobial stewardship? Before we will start, let us listen to the small video and complete our presentation.
Hi there. Did you know that 70 years ago, penicillin saved countless lives in World War II? Fast forward to the 21st century, and the chief doctor in the UK calls for antimicrobial resistance to be put on the National Risk Register and be taken seriously. And the US government describes antimicrobial resistance as one of our most serious health threats. In Canada, outbreaks of superbugs frequently make headlines because they kill patients. Antimicrobial resistance isn't a new phenomenon. All germs have the ability to develop resistance. But the more drug exposure there is, the faster resistance develops in people, animals, and agriculture. We now face infections that are resistant to many, if not all, of our available drugs, and there is very little to look forward to in the antibiotic development pipeline. Since 2010, only 3 new antimicrobials have been approved for use in Canada. This means that we must manage these precious resources more wisely, like preserving clean drinking water or halting global warming. Inappropriate or unnecessary use of antimicrobials is often cited as up to 50%. Misuse of antimicrobials is risky to patients. It can increase mortality, time spent in hospital, and lead to collateral damage, such as a new infection with another bug, like C. difficile, a germ that causes diarrhea.
صوت يا دكتورة إيمان.
Everyone wants to do the best thing for their patient. Sometimes that feels like wanting to give the strongest, broadest spectrum antibiotic. But we need to ask, is that really the best thing? Not just risky to patients. It can increase mortality, time spent in hospital, and lead to collateral damage, such as a new infection with another bug, like C. difficile, a germ that causes diarrhea in most, but may cause serious or fatal infection in others. Using antimicrobials appropriately will not only help preserve our antibiotics, but will also improve patient outcomes and patient safety. Everyone wants to do the best thing for their patient. Sometimes that feels like wanting to give the strongest, broadest spectrum antibiotic. But we need to ask, is that really the best thing? Not just
After we listening to this video, we already know why this is antimicrobial stewardship is important. This is for improving the patient outcome to decrease the resistance of antimicrobial. At the end of this video, we already know that antimicrobial antibiotic already increased the resistance in the latest period, because this is antibiotic already, when we already increase the resistance of increase the use of antibiotic, this is already driven by overuse and improper use of antibiotic. So the resistance of microorganisms increased. so we can use the stewardship. But why this is use this program? To increase the improve patient outcome, decrease or reduce the microbial resistance, decrease the spread of infection caused by multi-drug resistant organisms, help clinicians improve clinical outcomes, protect patients from harms caused by unnecessary antibiotics. Also, to optimize the use of antimicrobial medicine in human and animal health, reduce the incidence of the infection through the effect of hygiene and infection prevention measures, to increase the awareness and understanding through the effective communication and education training. Before we start the program of stewardship, let us know what is the definition of some words. What is this one? This is antimicrobial resistance. What is the meaning of antimicrobial resistance? The antimicrobial resistance or microorganism, this is such as a bacterial or fungi, this is or parasite change due to exposure or for antibacterial or antimicrobial, antibiotic, and antifungal, and so the decrease of use of, and so the increase of uses of antibiotic makes this one more resistant for uses of antibiotic. What does the meaning of antimicrobial? The real meaning of this one, it is an agent that kill microorganism or stop their growth. Antimicrobial medicine, which can be grouped according to microorganism. They act primarily against, for example, the antibiotic which used against the bacterial and the antifungal which used against the fungi. The antimicrobial stewardship program, what is the meaning of this one? This antimicrobial stewardship program, this is a systematic effort to use, educate, and resist prescriber, this is who already prescribes the medication, and antibiotic and antifungal and antibacterial of antimicrobials to follow the evidence based of guidelines in order to stem the evidence antibiotic to overuse. We have two principles of antimicrobial stewardship. What is this one? This is two main strategies. One is improve the appropriateness, and the other is minimize the adverse effect. The other one through the decrease resistance of the antibiotic and decrease the toxicity and decrease the cost to get the good outcome. And the stewardship is what is well achieved by promoting the selection of optimal antibiotic regimen dose, duration, and route of administration. We have core elements for the program of antimicrobial stewardship. Core elements before implementing stewardship program, this is 7 core elements. This is have a lot of roles and empowerment and leadership, commitment and accountability, and responsibilities, and educations, training, monitoring, surveillance, and reporting. Each one of them has a lot of responsibilities, and the first one is leadership and commitment. Leadership must detect necessary human, financial, and resources, ITs, resources to be powerful for the other team. The accountability, this is the one who will be the other one to responsible for a program outcome. Drug expert will be the one who will give the team the all information about the drug. Action, this is the one who will make implementation and intervention to give the antimicrobial stewardship the the importance. The tracking will get us the impact of intervention. Reporting everything will make already in the antimicrobial stewardship must be reporting to the committee. Education after the antimicrobial stewardship must give all the staff in healthcare education, and healthcare workers must give the education. There is one question must be already given to the hospital. Is there your hospital have antimicrobial stewardship team in your hospital? Yes, and you are the one part already of this one? Yes, and you are not a part of this team? No or not, and it will be on the future or not, and this is not in the plan. We make a lot of surveillance and a lot of results already give of the huge surveillance, and we already make the result already. The antibiotic stewardship must be implemented in all hospitals due to the importance of antimicrobial stewardship in the hospital. The first one of the informed antimicrobial stewardship is a team. How can we make start from a team? From which one the team of antimicrobial stewardship formed? From a physician and clinical pharmacist, infectious disease and clinical microbiologist, infection control, nurses, laboratory, and quality and patient safety. And this is all under umbrella of leadership and management. This must be in the committee of antimicrobial stewardship. And this committee have a lot of function and responsibilities and must have a lot of rules to be empowerment for all healthcare workers in the hospital to make the program of antimicrobial stewardship. What is the function and responsibilities of this antimicrobial stewardship committee? This committee must be a part of a big committees in the hospital, like pharmacy and therapeutic committee, infection control committee, patient and safety committee. What is the function of this and responsibilities of this committee? First, to promote and appropriate antimicrobial use among hospital and health system. Also, provide and for continued education related to antimicrobial stewardship, to track the antimicrobial stewardship initiatives and antimicrobial resistance. Also, the frequency and the meetings of antimicrobial stewardship must be regular and held on regular basis. Ideally, it must be continuously at the first of forming this stewardship program. And after that, it must be ideally months. And this one must be, like same before, must be a part of pharmacy and therapeutic committee, infection control, and patient safety committee. This committee must be documented, and everyone have a minutes of meeting for the other one, pharmacy and therapeutic committee, and patient safety committee, and the infection control committee. This committee already, the antimicrobial stewardship committee, when it's already formed, and all teams must have missions and the challenges. What is this missions and the challenges? This missions already to optimize the clinical patient outcome with regards to selected dosing and the duration of antimicrobial while reducing toxicity, preventing resistance, and reducing cost. What's the challenge? The challenge to achieve the mission and meet the new standards with limited resource. Because before meeting this challenge, there is a lot of obstacles will face the committee to apply or to implement the antimicrobial stewardship. Maybe financial pushback from physician due to resistance or pre-authorization when they start to make the order and not apply for the patient directly, and must be pre-authorization before due to guidelines. and lack of appropriate personnel, and also not follow guidelines before. In this case, what is the role of leadership? Leadership must make some roles, but the key words in these roles is empowerment, shared leadership, and distributed leadership. How they will make one demonstrated the value of antimicrobial stewardship, focusing on empowerment frontline physician to take over individual responsibility, and also potential strategy to improve the outcome in the children receiving antibiotic or interventions. So let us start now after making all these things. How implement and put the plan and the strategy. We have now regulations and guidelines of antimicrobial stewardship. Now we already make supporting and the technology and the data already what we have and what we do and what we will do to implement antimicrobial stewardship. And after that, we make awareness in the training and education for all healthcare workers about antimicrobial stewardship and what is it important and why is it important. And we have guidelines to implement this one. After that, we will start, but with basics. What basics? We have educated staff developed and updated with the standards and medical records updated. We have review for all patient medical records. We have updated guidelines already we will follow. We have restricted antimicrobial steward, restricted the antimicrobial food. We have surgical prophylaxis antimicrobial stewardship. We have a lot of things that we already put on basis, and we will follow up, started to make our project. This is what we already do when we already start to make implementation for antimicrobial stewardship. Just patient coming for us, and we will start to implement our stewardship and decrease a lot of antibiotic or antimicrobial steward that he already received. The doctor started to give him the appropriate antimicrobial or antibiotic for treatment for him according to guidelines or based on guidelines that he received. Prescribed, he will verify and orders according to those frequency, route of duration, review again for appropriateness. After that, stop treatment according to the duration. This is the example for preoperative prophylaxis guidelines, indication for surgical preoperative guidelines, and stop preoperative after 24 hours. The preoperative guidelines for the patient, this is must be full guidelines what we already put in our healthcare system. Patient will go for preoperative before, within, or 60 minutes. Take the preoperative guidelines must be stopped after 24 hours from receiving the first dose. This is the prophylaxis antibiotics. What we'll do after we already implement our project? Monitoring. How we will monitoring? By follow-up restricted antimicrobial stewardship for that we already put for all healthcare workers position, that we already make limited use according to some cases that we already fixed in the committee according to the use of antibiogram already results from lab. After that, follow up the compliance rate of preoperative guidelines according to the cases that we already implement and that we already received in our healthcare hospital. Calculate the consumption of one of restricted antimicrobial, and when we already started to calculate the consumption of one of restricted antimicrobial, we have criteria to select one of restricted antimicrobial. This antimicrobial must be broad spectrum, expensive, and increased in usage. Again, calculate the consumption, the cost. So how we can make this one of monitoring? We will apply the metrics. What is metrics we will calculate or use? We will make define daily dose. And what is defined daily dose? This is DDD. And we also have length of stay and also have days of therapy. Let us know what is defined daily dose. Defined daily dose, this is the one of the methods that we can calculate the consumption antibiotic. This is the some average maintenance dose per day for a drug used for its main indication in the adult, as a specific by the world of WHO. DDT of our standard to 1,000 patient days. Right. How can we calculate? This is an example for calculating the metrics for patient use levofloxacin is 0.5 gram. This is according to WHO. Every antibiotic already have number of DDD in WHO. This one already, this patient already received number of 0.5 gram per oral OD 7 days. And the number of DDD of this patient, 70, and he already used 750 mg gram per day for 7 days. What is the DDD for this patient? The DDD for this patient is half of gram in DDD according to the WHO. So we will make the number of grams that he already used according to the calculation, the dose already that he used. And already we make not minus, we will make divided by the number of DDD of this levofloxacin according to WHO, and after that we will by 1,000, and after that we will make by 7 days. This is the number of 10.5 of DDD. This means this is the average. This means the average maintenance dose that he already received according to the duration of this patient and received medication in the days that he already stayed in the hospital. After that, the length of therapy or length of stay or length of treatment period in the medication, the number of days that patient received the systematic antimicrobial agent, irrespective of the number of different drugs. Therefore, a lot of or length or LOT will be lower than or equal to dot. Dot, it means defined days of therapy, because each antibiotic receives its own dot. What is the what after that we will talk about the advantage of defined daily dose, because this is the famous metrics that we already can calculate the consumption of antibiotics. This is the provided methods of measures of benchmark both within and between institute of normalized to patient days can be calculated in the absence of computerized pharmacy recorded by purchasing data. And also quotation should be exercised when making comparison between a service and an institute with the different cases. And metrics of the days of therapy. This is the number of days that can be patient received the antimicrobial according to his case already patient in the hospital. And this is already the dot for a given patient of multiply antibiotics will be the sum of dot of each antibiotic. This means when the patient already receive more than antibiotics, we will calculate the dot of each antibiotic and the other, and we will sum of each of both antibiotics. After we make our project of antimicrobial stewardship and implement this one, we have already outcome of antimicrobial stewardship. What we can know, how can we already make the calculation or indicators for outcome of antimicrobial stewardship? A lot of things we can make the outcome of our project. What is this one? Patient outcome. Because this is the very important thing to know what is the patient outcome. The patient outcome, we can calculate or instruct the patient outcome by the hospital mortality or length of stay of the patient to know our project already successful or not, or there is things can be managed or not. How can we already know the hospital mortality or length of stay? Length of stay, we can calculate it according to the days of therapy or DDT consumption of antibiotics that already patient receive in the days that he already received of antibiotic in the hospital. But number of mortality can be assessed in the hospital mortality committee or death numbers of the hospital. Also, the other outcome of the antimicrobial stewardship can be known by microbiology outcomes, by Clostridium difficiles. Also, when the this can be calculated by microbiology data, epidemiological data, infection control, surveillance data. This is all indicators that can indicators for our project to know this is already give us the indicators. This is already a project of our antimicrobial stewardship successful or not. Also, documentation of indication of antimicrobial stewardship, review of view data for selected patient of medication sheet or compliance of restricted antimicrobial stewardship, antimicrobial stewardship form for restricted antimicrobial, and also compliance with current guidelines of surgical prophylaxis antibiotic. This is by selection of current profile for patient and to know this is a compliance or not with according to guidelines, and also a compliance rate with prophylaxis antibiotic, or this patient received the current antimicrobial for prophylaxis according to his cases and with guidelines or not. The compliance rate for guidelines of antibiotic timing, this is received on timing within 60 minutes before antibiotic, before surgical or not. This is all outcomes that inform us this is compliance rate with antimicrobial stewardship or not. The last thing that we can already know for continuous improvement for antimicrobial stewardship, this is education and training. This is the role of antimicrobial stewardship committee. This is for antimicrobial stewardship. This is the one every healthcare workers must be knows and have documentation and education and training for everything related to antimicrobial stewardship. But the core steps for implementation and education program is maybe required for 2 or 3 days every work every days according to the hospital criteria, according to also the guidelines that we already have, according to the results that we already received from surveillance, that already received from outcome of the patient, outcome of the results that already known, we already success in the our program or not. This is all we already received to implement of antimicrobial stewardship to start and implement our stewardship program. Thank you. Let us start with complete with Dr. Iman about clinical intervention with antimicrobial stewardship.
السلام عليكم. Thank you, Dr. Dina.
شكرا فندم.
we will start next presentation with Dr. Iman. She will take us for Antibiotic Stewardship Program Strategies. Dr. Iman, she is a senior clinical pharmacist, worked in Saudi German Hospital. And she earned Doctor of Clinical Pharmacy in 2006 and Baccalaureate of Pharmaceutical Science in 2001 from Alexandria University. Dr. Iman, you can start, please.
Thank you, Dr. Beltagi. Thank you, Dr. Adina, for this informative lecture. Thanks for everyone for your attendance. I'm very happy to participate in to introduce this program and to share our successful experience in Saudi German Hospital, Medina. I will talk about the strategies of antibiotic stewardship program. And this is a part of how to implement stewardship program in hospital. We can see from this lecture the 10 years challenge for bacteria or antimicrobial. What we can see here, of course, as we know that the sensitivity of bacteria or microbe to antimicrobial now become less than before because of the resistance. Every one of us should know what is his role to combat this resistance and to help saving life. By the end of this lecture, you will be able to know the basic information about the strategies of antibiotic stewardship program, to recognize the most important interventions in this program, and to understand what is the role of clinical pharmacist in the implementation. During this lecture, we will go through the clinical pharmacist role, the interventions of the antibiotic stewardship, and the strategies. As we know, the antimicrobial stewardship program, it's a coordinated program that promote for the rational use and appropriate use of antimicrobial. So our target or our goal is safety, decrease the resistance, decrease the cost, decrease length of stay, and mortality. To implement this, we need to know the strategies that we will go through. We have core strategies. Two important things. We cannot start stewardship program without these 2 points. One of them, prospective audit with intervention and feedback, or what we call also back-end strategy. It's post-prescription review. The physician write a prescription and the clinical pharmacist or pharmacist make appropriateness and review, then give feedback and make intervention if needed. The second thing of the core strategies is a formulary restriction and pre-authorization. This before the dispensing. The physician write a prescription that based on hospital policy of restriction, there is a restricted form, there is a pathway for the dispensing of restricted antimicrobial. So this is the most important, as we said, core strategies in the stewardship. We will go in details in these 2 important things. Then we will go and talk about the supplemental strategies, which is a general implementation for all stewardship program, like education, guidelines, clinical pathway, combination of empirical therapy, then de-escalation based on culture result, conversion from IV to oral therapy, how to make those optimization, and the importance of implementing a computer and decision support electronic program in the stewardship. First of all, we'll talk about the strategies. The first thing, prospective audit with intervention and feedback. Simply to make a review. This is our role as a clinical pharmacist, and generally we have been received many questions regarding this point from other healthcare worker and from other hospital, how the clinical pharmacist can improve or make the rule in stewardship program. Simply, first, the physician will start to write antimicrobial based on the indication, based on hospital protocol, based on clinical experience. This prescription simply revised by a clinical pharmacist. Usually, there is important role for clinical pharmacists in all hospitals, but unfortunately, there is no enough clinical pharmacists in every ward or area. So, clinical pharmacists will train the juniors to doing this in other area, and the clinical pharmacists usually available in critical care area like ICU or cardiology care units. We will do appropriateness review, which is usually done for all medication, but here we will concentrate on antimicrobial. The appropriateness like we will check the drug to be right dose, right drug, right frequency, right route, right route of administration, therapeutic application, if there is any real or potential allergy or sensitivity, potential drug-drug interaction or drug-food interaction, if there is any variation from hospital criteria like policies or clinical practice guideline, and patient weight and other physiological information, and finally, if there is any other contraindication. This is simply the appropriateness review, which is done by clinical pharmacists or by trained pharmacists for all medication. One of this medication is the antimicrobial. The important thing, how to document this intervention. Especially, it's required for accreditation and for documenting and for research and for documenting our work. The drug-related problem or intervention should be first detected, then doing the review, giving feedback to the physician, and document this intervention in whatever, in a separate paper form, either to put in patient file according to patient to hospital policy, either to submit to the quality department, to submit to the supervisor or the quality pharmacist, and also this can benefit everyone when we collect the data later to make a search if there is many many interventions from clinical pharmacists toward this one medication. So this means that more education needed, or we can make a policy or guidelines for this medication like that. The most important intervention, of course, it's regarding appropriateness for dosing regimen, like the dose, if the dose is right or no, frequency, if this taken once daily, twice daily, route of administration, duration, as we know that there is studies show that using antibiotic for a duration more than needed, more than guidelines stated, this increase the length of stay of the patient, make more adverse drug event to appear, and the bacteria become more resistant. So duration is really an important thing in our following antibiotic or antimicrobial duration is very important as our rule of clinical pharmacists to follow the medication. Dilution, rate, and the dosage form. All of this regarding inappropriate dosing regimen. All of this in the next two slides is a clinical pharmacist intervention in antibiotic stewardship program. You can make it in one paper, and as we make in Saudi German hospital ICU, like you can make no indication for drug therapy. You can found that this antimicrobial have no indication, like some patient admitted to the hospital without indication for antibiotic, and there is antibiotic prescribed, so we should discontinue. No drug order for medical condition. Maybe there is antimicrobial needed for this indication or missed. Inappropriate drug selection, whatever. It's inappropriate regarding the if it's renal patient or not suitable for this indication or not suitable for this age of patient, of weight, all of this consideration. Maybe there is a therapeutic duplication. An important consideration in the intervention is to discontinue. One of the most intervention made by clinical pharmacists to suggest to the physician to DC the antimicrobial, to discontinue the antimicrobial, that it extends the duration, or there is any adverse drug event appear, or there is no need, the patient, there is improvement. Okay. Also, you can recommend a drug therapy for patient status. You can recommend an alternative. You can make a dosing calculation if required or needed based on patient weight, based on loading dose or maintenance dose. We can make dosing optimization for medication in case of sometimes there is improvement of renal function after the sepsis improvement. So you can suggest to increase the dose or increase the frequency. Also, there is an important intervention in all antibiotic stewardship program that to make extended duration of carbapenem antibiotic like meropenem or piperacillin tazobactam. There is a studies that show that this antibiotic if used in extended duration, this increase the effectiveness and like increasing the dose. So this simple intervention you can implement in your hospital just by make education and make policy, educate nursing, educate physician that some types of antibiotic no need to give it within 30 minutes. No, it could be given within 3 to 4 hours, like piperacillin tazobactam, and this is one of the very easy intervention, simple and also effective. One of the intervention also, if it's incorrect protocol of stage of treatment, as we know the guidelines or protocol in hospital, like for sepsis, there is a combination of antibiotic. If a physician write a medication which different from our hospital protocol, you review and ask the physician and show him your reference, and this will be an important intervention. Another intervention that prescribed drug not administered, whatever the reason, maybe non-availability, maybe missed, and it's a medication error. Also, there is a lab and diagnostic test clinical pharmacist can recommend. We can just give some examples like band culture, which is important to give to all patients with sepsis or with other indication before the first dose of antibiotic given. So one of our rules that you should check, there is a culture taken and sent to lab. Another thing that you can recommend monitoring for some antibiotic like vancomycin or gentamicin or amikacin, which is the medication, which is the dosing will be based on the result of this trough level or AUC level. Another intervention, if the patient experience adverse drug reaction, either allergy or increase the QT prolongation or increase in liver enzymes, or some medication like colistin or vancomycin have a high tendency to make AKI. All of this, that adverse drug reaction, that clinical pharmacists should monitor, should follow up, and should give his recommendation for the physician. Second important thing is drug-drug interaction. Drug-drug interaction, one of our important thing also, especially for antimicrobial. Some antimicrobial, if you give together, can make adverse drug reaction, adverse drug event. Like you cannot give, for example, colistin or vancomycin with aminoglycoside. This increases the risk of acute kidney injury. Also, some antifungal, when given with antibiotic, this may increase or make hepatotoxicity. And also there is some antibiotics, if given together, it will be increase the risk of cardiac toxicity and QT prolongation, like azithromycin with voriconazole. All of this should be monitored and suggested solution by clinical pharmacists to physician. This is usually our area. Most of our drug information requested will be for regarding drug-drug interaction. But important thing that I want to mention also, that not every drug-drug interaction or antimicrobial interaction should be considered or should be discontinued as a result. No, there is a significant interaction and there is a level, as we know. If the level is X, so it's completely contraindicated. If given, it will lead to significant event. There is C, like just monitor for liver function, monitor for QT prolongation, and there is A or B. These levels consider non-significant drug interaction. Another intervention, that IV to oral switch, which is not usually suggested in critical care area. Most of the patient sepsis or unconscious, or there is you cannot give them oral, they cannot tolerate enteral feeding, but it's an important in ward patient or before discharge to shift the IV to oral antimicrobial. And the most important outcome also, that it will decrease the cost for antimicrobial, decrease the risk of infection, because usually, as we know, that intravenous, any less intervention for patient, less injection IV, this will lead to less hospital-acquired infection. One of the most important intervention also is renal dose adjustment. Actually, our statistics show that renal dose adjustment and de-escalation is the most two important interventions suggested by clinical pharmacists. Renal dose adjustment, most of antimicrobial need a renal dose adjustment. Most of the, especially when there is decrease of creatinine clearance, or there is intermittent hemodialysis, or there is a continuous renal replacement therapy. All of this should be considered, and the dose suggested by clinical pharmacists. Hepatic dose adjustment, some medication like tigecycline or some antifungal need hepatic dose adjustment. Antibiotic de-escalation, which we will talk about later. Why we make de-escalation? For many reasons. How to make de-escalation? De-escalation simply, it's from broad spectrum antibiotic to narrow spectrum antibiotic. So it's regarding type of antimicrobial, also number of antibiotic. You can start with a combination, and after a culture results or patient improvement, you will de-escalate. You start with 3, now you can de-escalate to 2 or 1. Also, the de-escalation includes the dosing. We can start with maximum dosing in case of patient with sepsis, then we will decrease the dose. All of this under the title antibiotic de-escalation. Clinical pharmacist, if you found any medication error or near miss, you should detect, correct, report, and discuss and review with the physician. Medication error usually in antimicrobial, which needed renal dose adjustment. This is mostly the error that we can find. And you should answer any drug information requested by physician, by nursing, and by other pharmacists. All of this intervention for clinical pharmacists, you can make it in a one form, and you can document your information, make statistics either monthly or quarterly. You can make a search which one of this intervention, because it will result in outcome. One of the options that we make in Saudi German Hospital Medina ICU, that we document what is the clinical significance expected after this intervention. Is this clinical significance potential, severe, or it's just important, or it's minor or low clinical significance? And also regarding the cost or the ADR. The de-escalation may have cost saving, may have also potential ADR toxicity prevented or enhanced therapeutic effect. One of the important things that you should document and consider in your intervention, that's the acceptance. Your intervention accepted by physician or rejected, may be modified. He agree with your suggestion with the antibiotic, but he have a concern regarding the dose. Unknown means that maybe this intervention you don't know the patient transfer or discharge dama, just put in your documentation. This simply the clinical pharmacist intervention in the antibiotic stewardship program. Now we will go to the second part of the core strategies, which is formulary restriction and pre-authorization. All of the hospital which started antibiotic stewardship program that face this issue. How to make a restriction? What is the importance of this restriction? The restricted antimicrobial agent is simply an agent which requires prior to dispensing authorization or approved the protocol by the ASP committee. Usually this antimicrobial, we make a list of restricted form that the pharmacy cannot dispense without a restricted form approval from clinical pharmacist. So starting from physician, when he wants to write any of this list, he should write the restricted form, and this form should be approved first by clinical pharmacist, then the pharmacy can dispense it. Regarding the first few doses, clinical pharmacist is not available 24 hours and not in all hospitals, and also not in weekends, for example. Also, there is some situation like critical situation, sepsis patient, that the medication should be given within 1 hour to decrease the mortality. All of this condition, the guidelines highly recommend that the first few doses of antibiotic, and these few doses specified according to hospital policy, maybe 1 or 2 doses which is prescribed in the night or in the weekend. Then after that, the clinical pharmacist can check these doses and check this list and approve or discontinue from the restricted form. So in the guidelines and hospital policy that considered first few doses could be dispensed from inpatient pharmacy, even there is no approval from clinical pharmacist or from ID physician. Now for the restricted form. How to design a restricted form? It's an important question that everyone started antimicrobial stewardship face at the beginning. We should know that there is no magic restricted form. If there is a universal restricted form, it will be something easy and all hospital, we will put this list. But there is a highly difference according to national guidelines, according to hospital protocol, according to available medication. All of this make the committee or the team suggest a list. As an example, here there is a restricted antimicrobial agent. This example that suggested from guidelines, national guidelines in Saudi Arabia, Ministry of Health, that suggest which antimicrobial agent that should be in the restricted list. As we can see here, antibacterial, antifungal, antiviral, and antiprotozoal. We cannot say that we should write everything in our restricted form. You cannot make restricted of one antibiotic and it's not available. We cannot make it, of course. First, we will ensure that this antimicrobial is available in our formulary or no. If this antimicrobial is not abused or not used irrational, so no need to add in some medication which is rarely used for some indication, so no need at all to put in your restricted list. Usually, the broad spectrum antimicrobial is put in the list. Also, the new antimicrobial and also the highly expensive. For example, our list in Saudi German Hospital did not add any antiprotozoal or antiviral medication. We put antibacterial, some antibacterial and antifungal, and also in other hospital the same. So, the restricted form. How to design a restricted form? An important question that many of hospital asked before starting this. So we are happy to sharing our success story in implementation of restriction and pre-authorization in Saudi German Hospital Medina ICU. This is simply the most important thing that you should consider in the restricted form. By the way, if you make it simple, it will be used more easier. It will be easy in monitoring, easy in implementation. For example, of course, you will make this space for patient information. There is antimicrobial agent. You should list it. Maybe you can specify if it's antibacterial, antifungal, or antiviral. So you should mention and list and educate. In some GCI or Sebahi surveyor, they ask the nurses or physician if this list is, if this antimicrobial is restricted or not. And it's unlogic that if this restricted list implemented from 1 year, that one of the ICU nurses that asked if this restricted or not. So education is important. You should be sure in the monitoring that everyone included in the stewardship program, whatever physician, pharmacist, clinical pharmacist, nurses, that know what is your list in antimicrobial. And if there is any update, if you exclude one or you add another one, this is the essential thing that should be known by all the healthcare worker involved. Also, you should write if it's empirical or culture-based. If it's empirical, so there is some comments needed by physician, or at least you can put some data like clinical data, fever, or any lab data like CRP or white blood cells, any radiological data like X-ray. All of this you can specify and mention it to make easy for physician and save time. And also you can put just a comment for physician. If it's a culture-based, you should mention if it's wound, blood, sputum. You can add, it's optional to write if it's initiation or continuation, if it started in your area, ward, or ICU, or it's a continuation from other ward. We should have also comment from physician, comment from clinical pharmacist. The clinical pharmacist can review like follow-up culture, or you can dispense it for 2 days and de-escalate when the result of culture cleared. And if there is any follow-up needed, like after a few days, you should, if there is any change in the renal function, you should change the dose, or there is any culture result appear, so you should discontinue, for example, the anti-gram-positive antimicrobial, because there is no data appear. And also there is consideration that you should make a part for pharmacy. The inpatient pharmacy is important, that they should have like a signature or comment that you can follow up and monitor if this antimicrobial dispensed without restricted form or with. You have also the choice to make it one paper or a copy. You can keep the copy or in the patient file, in inpatient pharmacy. All of this according to the hospital policy. And to make it easy, it will be better and will be easy for physician to write this, easy for clinical pharmacists to review, easy for inpatient pharmacy to dispense. Now we talk about the ASP core strategies. We will go to talk about the supplementation strategies. supplemental strategies, which is some strategies it's important in ASP after the core strategies. What is this supplemental strategies? Like education, as in our first lecture. Education is important when, especially when starting the program, like orientation, when you monitor for when you need when you monitor and found there is some points missed by the staff, you should educate. When there is like a new thing, like new medication added to the formulary, new antimicrobial, I mean, or there is any changes in the restricted form. But studies show that you cannot depend only on education. You cannot just educate physicians and pharmacists the importance of restricted form, and you did not, and not to implement restricted form. Education has shown marginal result in the outcome. It should be one of the strategies, not the only strategies. The other thing, to put a guidelines and clinical pathway. As we know in first lecture that a guidelines should be put and in the hospital, it will be more easy for physicians that if there is a guidelines for sepsis, for preoperative prophylaxis, if there is a form ready just to put a sign on the medications. Clinical pathway, it will be important for all the included team. Combination empirical therapy and de-escalation strategy, it's very important also. How? Usually in the patient, in some indication like sepsis, we started with empirical therapy. We put more than antibiotic and sometimes antifungal. It's very important to make to take culture for the patient before this antibiotic started. Then you should de-escalate as soon as possible. The de-escalation will depend on many factors. One of the important factors that lab results. If the lab results appear within even preliminary results within 2 days, it will be more easier for clinical pharmacist and physician to de-escalate. But if the lab result delayed for any reason, you cannot make de-escalate on evidence-based. Also de-escalation, if there is ID physician in the hospital, or there is a clinical pharmacist in the critical area, this you can, if you can make check the culture, check the patient medication, check the lab result every day, it will be more easier and logic to de-escalate and to implement this de-escalation strategy. De-escalation, one is the important thing is the antibiotic stewardship, because it will decrease the number of antibiotic and the dose of antibiotic. From, as we mentioned, from broad spectrum to narrow spectrum, you will decrease the resistance of the bacteria, and also will decrease the cost, decrease the adverse drug event for the that may appear to the patient, decrease the length of stay, saving time for even for medication administration for nurses. Conversion from IV to oral therapy need some specification we will talk about later, and antimicrobial dosing optimization, as we mentioned, for the extended duration of carbapenem medication like meropenem or piperacillin tazobactam, and also dosing optimization, like you can increase the dose to maximum dose if indicated, you can optimize the dose if there is any improvement in renal function. Computer surveillance and decision support will highly affect the medication, the antimicrobial stewardship positively. If there is a guidelines already on the system, if there is any decision support, if the physician wrote the medication electronically, all of this will make it more easier, more the decision support will be more easy, saving time, decrease the medication error. This is a simple diagram that when to stop or de-escalate antibiotic. If there is any clinical improvement, yes, you can make it de-escalation or discontinuation. If the patient tolerating oral medication, so you can consider to switching. If the oral option available, maybe the patient can tolerate, but the antibiotic only intravenous intravenous form available. You can also switch the antibiotic to or de-escalate to narrow spectrum antibiotic. Okay. Also, you should review if the patient really now still need antibiotic or no. The guidelines for many indications like this should be given for 2 weeks. So if you find the antimicrobial more than 2 weeks, you should review and check why, if there is any indication still needed, and if needed, still in this dose, is this dose optimized? Can we make the escalation to narrow spectrum? Can we shift the patient from IV to oral? Regarding this switching, of course, it's important, but we cannot make it in all patients, as we mentioned. We cannot make it usually in the ICU patient. We should be sure that the patient is not nail by mouth, like some patient in ICU. You should be sure that this patient tolerating enteral feeding. The oral absorption is not compromised. Maybe the patient having vomiting, or there is any, the GIT is not intact, or the patient cannot tolerate the oral medication. All of this should be considered before shifting from IV to oral switch. I'm very happy to sharing our success story and successful program, antibiotic stewardship program from Saudi German Hospital. And just stress that every one of us should have a role in implementing the stewardship program to decrease the bacterial resistance, to decrease the cost, to improve the safety of patient, decrease the side effect, saving life. Everyone should know his role, and there is no minor role. This webinar is one of the webinars that we make before the Arabic one and the campaign during the antimicrobial week, International Antimicrobial Week, which is supported by Ministry of Health, the Administration of Pharmaceutical Care Administration in Medina. We are very happy to, as a Saudi German hospital, to share with the Ministry of Health this webinar for the education for healthcare professional, and I hope everyone that know his role, and we are happy for any questions or inquiry about how to implement this antimicrobial stewardship program. Here our home message at the end. I promise to do my part in combating the development of antimicrobial resistance. I hope everyone can do and have a role to improving the safety of antibiotics and antimicrobial and decrease the resistance. I promise to do my part. How about you? Thank you very much. بسم الله الرحمن الرحيم. ومن أحياها فكأنما أحيا الناس جميعا. صدق الله العظيم.
Thank you, Dr. for this fruitful presentation. Thank you very much. بعض الأسئلة هنا من المشاركين. طبعا من الأسئلة عن الساعات يا أستاذ علاء CME hours، أنا جاوبتهم وقلت لهم إن في 3 ساعات، بس في بعض الناس بتسأل برضه إمتى هتنزل الساعات. دي أول حاجة بس أستاذ علاء ممكن يفيدنا فيها.
السلام عليكم ورحمة الله. بخصوص الساعات إن شاء الله there is 3 CM hour CBD hour. إن شاء الله after we finish this webinar, kindly from Dr. Imani, please stop sharing.
Oh, okay.
Thank you a lot. For inshallah for CM hour, it will be inshallah 3 CM hour for this webinar. But kindly after we finish this webinar, please log into www.smartpodium.sa to fill the evaluation form, and then inshallah you can everyone who attend can download his copy from his certificate, and inshallah within 2 weeks we'll inshallah send all the CME hour in Mumaris Plus. Thank you, Dr. Muhammad.
شكرا يا استاذ علاء. في بعض الاسئله يا دكتوره ايمان ودكتوره دينا. في سؤال هنا بيقول what I will do in case of secondary bacterial infection. يعني what I will write مثلا the diagnosis. نعمل ايه في الحالات اللي زي دي؟
Secondary bacterial infection diagnosis. This is a question from a physician or what? Sorry.
I don't know والله. His name is Ahmed الشهاوي. Maybe he's a doctor.
If there is a secondary bacterial infection, we will treat it like the same protocol, that if there is any signs of infection, if there is a culture needed, still the result pending, we will go through our the hospital protocol or national guidelines for empirical antibiotic therapy. If this antibiotic restricted, so we will use the restricted form. If there is any result appears that we can de-escalate again. Secondary bacterial infection may be hospital acquired, that we have our antibiogram, we have usually the result or previous data of our hospital infection or common infection. I hope that I answer the inquiry.
Yes, thank you. يعني we will follow the guidelines of
Yes.
Second question, ask about the impact of this program on the hospital.
Yes.
طيب, can I answer this question?
Sure, doctor.
impact أو الفوائد بتاعة البروجرام ده يا شباب. أول حاجة البيشنت سيفتي. أول حاجة احنا قللنا الانتيبيوتيك أو الانتي ميكروبيال ريزيستنس، فعملنا امبروف للبيشنت سيفتي. تاني حاجة اللي كبرايفت هوسبيتال يهمنا جدا موضوع الكوست. ان احنا قللنا الكوست وزودنا قللنا الكوست بتاع الانتيبيوتيك اللي احنا بنستخدمه، وزودنا البيشنت سيفتي. ففي حاجتين اتنين، بيشنت سيفتي وكوست على الانتيبيوتيك اللي احنا بنستخدمه. لو عايز اضيف حاجه يا دكتور.
لا agree طبعا with Dr. Biltagi, head of pharmacy, and I think he is one of our team of antibiotic stewardship program, and he can يعني monitor and follow up our the result of use of implementing antibiotic stewardship program, like for antimicrobial prophylaxis, how we change from third generation to first generation. We can also check the from infection control and lab that the our antibiogram, the Clostridium difficile results, that it's decreased or not. All of this, as Dr. Dina mentioned, is a positive outcome, and of course the cost.
تمام. في برضه سؤال هنا بيقول if the patient, I have patient with E. coli has UTI that is resistant to all medicines. What shall I do in this? Resistant to all antibiotics.
The issue of multi-drug resistant bacteria is a common in critical care area, especially ICU. There is the incidence of this MDR bacteria, and there is a specific guidelines to manage. Usually, this antimicrobial, first we should be sure that this general, as a general note for this patient, we should be sure that there is a signs of infection, because sometimes there is a contamination. There is a bacteria, but there is no infection, so no need for antibiotic at all. First, we check that there is UTI. There is some interventions can make by a physician suggested, to change the case if there is any policy or protocol in the hospital. Then some bacteria we can use either a combination, or there is one of the antimicrobial in the maximum dose. We can optimize the medication, like to using the optimization of the dose, extended infusion. We can use like loading dose of one of the medications and shift to maintenance dose. So every hospital should make a protocol for managing of MDR by using a suitable medication. Then we can monitor and follow patient. If there is a culture, we will follow also and make de-escalation like that.
تمام. برضه في سؤال يعني متكرر. What is the meaning of multi-drug resistance? Is it for life?
Multi-drug resistant, there is a definition. It means that this bacteria become resistant to one or more of antimicrobial classes. Okay, this consider MDR. And there is a difference between MDR and ban resistant. Ban resistant, which is resistance to all antibiotics that it should be sensitive. MDR, one or more of the, two or more of the bacterial groups. Sometimes this bacteria, after management with antibacterial, this bacteria, and we'll make another culture later, it will be managed or not available in the not appear again in the culture. So sometimes it's not for life, of course, it's changed, the patient condition changing and the bacteria condition, the bacteria changed. But usually we have a concern for this bacteria because it's really affect patient condition, increase the mortality. Many patients have a multi-drug bacteria but have a positive response. But some patients, especially in ICU, elderly, have a renal and comorbidity or elderly patient. So this bacteria may cause increase the mortality for this patient. So usually and that's why we make this education and make stewardship program to decrease the resistance of the bacteria. And the important thing, the duration of using of antibacterial. This is the important thing that affecting really the resistance.
شكرا دكتورة إيمان. في بقى بعض التمرينات عايزين لينك يا أستاذ علاء على عشان يعملوا ايفالويشن للسيشن. لو في ممكن لينك كده تبعته عشان يعملوا ايفالويشن ونشوف لو في امبروفمنت نقدر نعمله في المرات الجايه ان شاء الله ممكن نعمله.
تمام دكتور، الحين ان شاء الله نرسله ان شاء الله على الشات للكل ان شاء الله.
تمام، ده كل الاسئله اللي معانا. لو في اسئله تاني
اظن كده يا دكتور خلاص، يعني ما في اسئله اظن.
لا خلاص ما فيش حاجه.
طيب
بس تفضل دكتور. خلاص متشكر.
الكلمه ليك دكتور، تفضل.
طيب انا بحب اشكر الاتنديز وبحب اشكر الكوميتي اللي عملت الويبينار ده، وبنتمنى ان يكون افاده للجميع
ان شاء الله
واستفدنا منه. وان شاء الله لو في اي حاجه او في اي من الايفالويشن اللي هيتبعت لنا ده، لو في اي امبروفمنت ولا حاجه ممكن نقدر نعملها. وبشكر اللجنه المنظمه وبشكر كل الحضور وجزاكم الله خير.
الله يجزاك الخير يا دكتور محمد. بسم الله والصلاه والسلام على رسول الله وعلى اله وصحبه ومن والاه. اولا باسم الشؤون الاكاديميه والتدريب بالمستشفى السعودي الالماني، بحب اتوجه بالشكر الكبير لاداره الرعايه الصيدليه في وزاره الصحه، والدكتوره حنان تكر، الاستاذ علي، الاستاذ عبد الرحمن، كانوا فعلا بالنسبه لنا شركاء النجاح خلال فتره الاسبوع، فعاليات الاسبوع العالمي للمضادات الميكروبيه. وان شاء الله نحن مستمرين بالتعاون معهم الى ابعد حد ان شاء الله في خدمه المدينه واهلها ان شاء الله. وشكري موصول للرائعتين الدكتوره ايمان والدكتوره دينا، اللي هم خلال الفتره الماضيه يعني كان مجهودهم اكثر من رائع ما شاء الله بالويبينارز وبالفعاليات والله يجعله في ميزان حسناتكم يا دكتورة إيمان ودكتورة دينا. يعني شهادتي فيكم مجروحة والله. اما الانسان الرائع الدكتور محمد بلتاجي فعاد انا ما اقدر ايش اقول لك، يعني انت كل ايفنت انت الجندي المجهول خلفه، يعني فعاد الله يجزاك الخير على كل شيء بتسويه. الله يسعدك. انا حابب بس اقول شيء، انه نحن ان شاء الله حيكون عندنا كورس قريب ان شاء الله يوم 23 جانيوري، حيكون كورس بيسك ميديكيشن سيفتي عليه 24 CMA اور. also there is 24 CBHQ hour for quality for NBHQ certificate. دكتورة دينا لو حضرتك تفضلي تتكلمي عنه أحسن مني، تفضلي.
لا يا فندم، العفو. لا، هو البيزك ميديكيشن سيفتي عليه 24 ساعة من الهيئة الصحية للتخصصات، وكمان 24 ساعة أبروفد من الهيئة من NAHQ، تستخدم لتجديد ساعات CBHQ للناس اللي معاها ساعات CBHQ. يعني هو الدكتورة إيمان كمان ليها الفضل فيه معانا في الكورس ده، تقدر تتكلم فيه معانا كمان. تقدر دكتورة إيمان.
شكرا أستاذ علاء، شكرا دكتور محمد، شكرا دكتورة دينا. إن شاء الله يكون الفايدة عامة للناس كلها في البرنامج بتاعنا النهاردة. وبخصوص الميديكيشن سيفتي كورس تو انهانس يور نوليدج، ان شاء الله يبقى في كل الديتيلز اللي محتاجها اي health care worker, physician, nurse, pharmacist, clinical pharmacist regarding everything about medication safety in details.
تمام، الله يعطيكم العافيه دكتور ايمان ودكتور دينا، وان شاء الله موعدنا مع الكل ان شاء الله يوم 23 الشهر ان شاء الله بالبيسك ميديكيشن سيفتي ان شاء الله. اخر شيء اللي بدي اقوله انه شكرا thank you to all attendees, thank you to my respective doctors that give this webinar. It was very fruitful webinar. Thank you a lot وجزاكم الله خير والسلام عليكم ورحمة الله.
شكرا جزيلا.